right, good evening, everybody. Welcome back to another episode of Pathagonia. This is Cole. I'm in a good mood. Just hit my cold plunge and feeling nice and relaxed, ready to do this video on lesions of the vulva. So this is a cool topic because it covers GYN pathology, but also because of the anatomy. Some of these entities are derm lesions, so a lot of high yield stuff. So let's go ahead and get started. So in the lesions of the vulva, the first category is non-neoplastic lesions, and the first of which is a classic lichen sclerosus. So formerly this was known as lichen sclerosus atrophicus, or you'll see sometimes LSA, this will be referred to as. So lichen sclerosus is an autoimmune disease. Most commonly occurs in postmenopausal women. Clinically, it appears as a white to red plaques with wrinkling and hypopigmentation, resembling tissue paper. It can cause pruritus and pain. You get sclerosis of the papillary dermis and atrophy of the overlying epithelium. I've heard it referred to as the red, white, and blue. So the red is that overlying epithelium, white is that homogenization of the dermis that you're seeing, and then the blue refers to that lichenoid band of lymphocytic infiltrate. So red, white, and blue for lichen sclerosus. So one in this image refers to the hyalinization and edema in the papillary dermis, also known as homogenization. Number two here points to some degree of vacuolar degeneration of the basal keratinocytes. Three is that blue or band-like lymphocytic infiltrate beneath the homogenized collagen. And four is that epidermal atrophy. So if you have atrophy of the epidermis, that homogenized collagen, and then that band of lymphocytic infiltrate, you want to think about lichen sclerosus. And lichen sclerosus increases the risk of differentiated VIN or DVIN. Next up, we've got lichen simplex chronicus. This is a non-specific pattern in response to chronic rubbing or scratching. Can be seen in association with other disorders such as Candida infection or contact dermatitis, which makes sense because those are entities that you may want to rub or scratch. And this can also be due to clothing or other irritation. Clinically, lichen simplex chronicus looks thickened, leathery, scaled, lichenification, whereas lichen sclerosus was more tissue paper. Lichen simplex chronicus has marked hyperkeratosis that we appreciate over here, with hypergranulosis, so increase of that stratum granulosum layer, and irregular epidermal hyperplasia. The papillary dermis is thickened with vertical dense collagen between the papillae that we see in this image. And if there's lots of spongiosis, you may want to consider contact dermatitis. And if there's neutrophils in the stratum corneum, consider getting a fungal stain such as a PAS or GMS. Next up, moving right along, Bartholin's gland cyst. So these are vulvar cysts due to the Bartholin gland duct outlet obstruction with subsequent retention of the mucinous secretions. So obstruction of the duct leading to cyst. They are located in the posterolateral vestibule, and there is this unilocular with smooth inner lining of non-keratinizing squamous, transitional, or mucinous epithelium. And on the right here we have these Bartholin glands, which can be seen in the wall of a Bartholin cyst. Moving on, we have plasma cell vulvitis or Zune vulvitis. This is idiopathic inflammatory dermatitis. Well-circumscribed erythematous plaques or patches may be seen with prominent lichenoid infiltrate of plasma cells. You'll see thinned epidermis with spongiosis. As shown here, we can appreciate the sponge and thinning of the epidermis with lozenge-shaped or diamond-like squamous cells. And this is going to present with itching or pain, and there's a wide age range, usually occurring in older adults, The differential diagnosis is syphilis, includes syphilis, so you may want to consider getting a spirochete IHC. So some non-HPV viral infections in the vulvar area that you may see are two classic ones. So you have herpes simplex virus, or HSV. This is a sexually transmitted disease, most commonly HSV type 2. Clinically, you're going to have pustules, which will become vesicles and ulcers. And the classic 3 M's of herpes are molding, multinucleation, and margination. And you will have the ground glass nuclear inclusions. You will see the inclusions in the squamous epithelial cells, and you can use the HSV IHC to confirm your diagnosis. So this top image, we have herpes simplex virus with the 3 M's. And in the bottom image is a classic image that you would see for molluscum contagiosum, which is caused by the pox virus. And in children, it can occur anywhere on the body through close contact. In adults, it's usually on the genitals, only as an STD. And clinically, you'll see these small, dome-shaped, smooth papules with a central punctum. And then histologically, you'll have marked acanthosis with eosinophilic intracytoplasmic viral inclusions, also known as Henderson-Patterson bodies. Moving right along, we've got candidiasis, another classic entity. Candida albicans can cause chronic vulvovaginal infections. Clinically, you're going to have erythema and pruritus. Microscopically, you'll have pseudohyphae that are present, which can be highlighted with PAS and GMS. And you will see psoriasiform hyperplasia, spongiosis with mixed dermal inflammation. And a good hint are intracorneal neutrophils and neutrophilic aggregates within the superficial epidermis. All right, moving on from non-neoplastic to tumors in the epithelium. The first of which is seborrheic keratosis, or an SK, classic derm entity, which is benign. Clinically, they're going to have this plaque-like stuck-on appearance, as shown here. And histologically, you're going to have varying degrees of acanthosis, hyperkeratosis, interlacing pigmented epidermal strands, papillomatosis, and keratin-filled horn cysts. So here are some horn cysts, classic for seborrheic keratosis. You're not going to really appreciate much significant atypia, and they'll commonly occur in older women, likely conventional skin, seborrheic keratosis. And in younger women, you often have HPV positivity, so it's good to consider condyloma acuminatum. All right, next up, a classic entity for the vulva is hydradenoma papilliferum. This is a benign entity, often presents as an asymptomatic nodule. It's virtually identical to intraductal papilloma of the breast. You'll have well-circumscribed subepithelial nodule with papillary proliferation with tubular glands. You can have apicrine differentiation with apical snouts, and there's going to be 2 cell layers. So you have the inner epithelial and the outer myoepithelial layers, which can be seen on IHC. So this is what it would look like at low power, and then at higher power, you'll see these papillary proliferations with tubular glands. All right, moving along, we have squamous intraepithelial lesion, or SIL. So of course, we have the same spectrum of disease as we do in the cervix and other areas of the body. So SIL, or squamous intraepithelial lesions, is an intraepithelial in situ non-invasive process of squamous dysplasia due to HPV infection. And first off on that spectrum is LSIL, or low-grade squamous intraepithelial lesion. In the vulva, it is known as vulvar intraepithelial neoplasia grade 1, or VIN 1. So within the vulva, most VIN 1 is limited to condyloma acuminatum, which is shown here on this image on the right, which is also important to remember that flat LSIL in the vulva is quite rare. So for condyloma acuminatum, also known as genital warts, It's grossly evident verrucous L-cell, composed of acanthotic papillary fronds with acanthosis, parakeratosis, and hyperkeratosis. There are often multiple, and condyloma acuminatum is mostly due to low-risk HPV, type 6 and 11. It's most common during reproductive age, and there's low risk of progression to cancer. Histologically, you're going to see a proliferation of hyperchromatic basal-like cells that extends no more than 1/3 of the way up the epithelium, and the cells differentiate or gain cytoplasm in the upper epithelium. So the mitoses are confined to the lower zone, that lower 1/3, and the epithelium is often thickened in L-cell or condyloma acuminatum. Many of the nuclei are hyperchromatic with irregular nuclear contours at all levels, and you classically see the coilocytes, which are large superficial cells with perinuclear halos and large irregular racinoid nuclei. Sometimes the coilocytes can be binucleated, and L-cell or condyloma acuminatum often spontaneously regresses, so you can observe it or do an excision, cautery, or treat it with imiquimod. Continuing on with our squamous intraepithelial lesion discussion, next up we have giant condyloma acuminatum, which is rare, very large HPV-mediated condylomatous growth. You're going to see coilocytes. It can be locally aggressive, and it's associated with immunosuppression with a potential for malignant transformation. Next up, we've got high-grade squamous intraepithelial lesion, or HSIL. So most flat vulva SIL lesions are HSIL, which are associated with high-risk HPV, usually type 16, and have a higher risk of progression to invasive carcinoma if left untreated compared to L-SIL, but not super high absolute risk. There's little to no superficial maturation in HSIL, and there's proliferation of hyperchromatic basal-like cells that extend 2/3 of the way up for VIN2 or full thickness for VIN3, which is also known as carcinoma in situ of the epithelium. So here's a good example of HSIL, and I guess this would be VIN2, as it's not quite full thickness. You have a little bit of maturity at the top. So this would still be high-grade squamous intraepithelial lesion, but it's not quite full thickness to get to VIN3 or carcinoma in situ. The cells have enlarged hyperchromatic nuclei with irregular nuclear contours and increased nuclear cytoplasmic ratios that we're all familiar with. And mitoses are common at all levels in high grade, including atypical mitoses. Nucleoli are unusual in HSIL and raise the possibility of inadequately sampled invasive carcinoma, which would be P16 positive, or metaplasia if it's P16 negative. So HSIL can colonize skin appendages, mimicking invasion, and treatment includes excision, laser ablation, and topical chemotherapy. So the classic discussion of when P16 immunohistochemistry should be used. So it's used as a surrogate marker of high-risk HPV infection. So you want to use P16 when the morphologic differential diagnosis is between HSIL and a mimic like metaplasia. So HSIL would be P16 positive. Some form of squamous metaplasia would be P16 negative. Or if you're considering a diagnosis of VIN2, which should be P16 positive, versus L-SIL, which should be P16 negative. Should be, but not always. Also, you can use P16 when there is disagreement between pathologists to help add more data for the discussion, or when there is a high risk for missing HSIL disease, such in patients that are HPV positive or positive for high-risk HPV strains. And then as far as what it would look like, so on the left we have P16 positivity, which shows strong diffuse nuclear and cytoplasmic block positive staining along the basal layer going at least 1/3 of the way up. So we would consider this P16 positive, whereas on the right we have an example of P16 negative, which would be weak or patchy, and this is technically anything that isn't block positive is considered P16 negative. So when P16 immunohistochemistry will not help is when the biopsy is unequivocally L-cell, H-cell, or negative morphologically, and when the differential diagnosis is between L-cell and negative, as both processes are P16 negative usually. Next up, we've got DVIN, differentiated vulvar intraepithelial neoplasia, which is HPV negative or independent squamous dysplasia. DVIN occurs predominantly in elderly women and is associated with lichen planus and lichen sclerosus. Histologically for DVIN, you're going to see basal cell atypia with nuclear hyperchromasia, with anastomosing of the reedy ridges, and atypical basal mitoses. Sorry. You're also going to see superficial terminal differentiation or cornification with hyperkeratosis and dyskeratosis, as well as abundant eosinophilic cytoplasm with prominent nucleoli. For IHC, DVIN is going to be P16 negative or not block positive, and P53 mutant with strong staining of all basal cells for P53. See the example down here to the right. So this is how P53 would stain in the DVIN. Strong positivity in that basal cell layer, which is where we're going to see that basal cell atypia. And the Ki67 is profoundly increased in DVIN. So there is a higher risk for quicker progression to invasive squamous cell carcinoma than normal VIN3. So for DVIN, the treatment is excision. Next up, we've got extramammary Paget disease. So this is an intraepithelial proliferation of apocrine-like cells, often occurring in older Caucasian women. Clinically, it's going to be often red or pruritic lesion with large round Paget cells with prominent pale cytoplasm and nucleoli spreading throughout the epithelium. They can be single cells or in groups or glands and can extend down into adnexal structures. It's important to rule out cutaneous pagetoid spread of urothelial or GI cancers with IHC, which we'll talk a little bit about below in this table. And the treatment for extramammary Paget's disease is resection, but there are high rates of recurrence, so Paget's can progress to invasive adenocarcinoma, and you can see some of this pagetoid spread throughout the epithelium. So in an entity like this, you would want to rule out, is this just pagetoid spread of a nearby urothelial or GI cancer? So to do that, you would want to look at various IHCs. So some of those include CK7, CK20, GCDFP15, CDX2, CEA, and more. And obviously, we're familiar with these IHCs and where they may be from. So I'm not going to read through all the positive and negative staining, but using our process of elimination, our IHCs can lead us to whether or not this is a primary Paget's disease, or if it's from the urothelial tract or GI, or you can also do melanocytic markers and make sure this isn't some kind of a melanoma or a melanocytic process. All right, moving on. Another entity is HPV-independent P53 wild-type vulvar intraepithelial neoplasia, or verruciform acanthotic vulvar intraepithelial neoplasia, or VIN. So this is an emerging diagnosis. You're going to see marked acanthosis, verruciform growth, and altered squamous maturation. There's no significant atypia, and you'll see hyper or hypogranulosis, as well as hyperkeratosis. For IHC, it's going to be negative or normal P16, and it is going to be P53 wild type by definition. You're also going to have varied names or morphology, such as differentiated exophytic vulvar intraepithelial lesion or DEVIL, vulvar acanthosis with altered differentiation or VAD, And this occurs predominantly in elderly women. Clinically, there's cauliflower-like plaques, and the molecular for VIN is PIK3CA and HRAS mutations, and this can progress to conventional and verrucous squamous cell carcinoma. So here's a table just to compare from modern pathology, just to compare the various types of VIN, or vulvar intraepithelial neoplasia. So we have HSIL, DVIN, and VAVIN. And again, all of this we've kind of already talked about, but just to have in a nice reference format, if you have a case and you're trying to differentiate what type of VIN you may be dealing with, be sure to reference this table just to have everything in one place. The next category are anogenital mammary gland lesions. So anogenital mammary glands can give rise to multiple tumors resembling their breast counterparts, such as fibroadenoma or phylloides tumor, which is a biphasic epithelial and stromal tumor, just like in the breast, adenocarcinoma of the mammary gland type, Paget's disease, as previously discussed, and myofibroblastoma. Moving on, so another entity that occurs elsewhere in the body and is very common is squamous cell carcinoma. So this is an invasive epithelial tumor composed of squamous cells with varying degrees of differentiation. Squamous cell carcinoma is derived from HSIL, so it's HPV associated, or differentiated VIN, which is HPV independent. Squamous cell carcinoma is the most common vulvar malignancy, most commonly occurring in the elderly, and the most important factor determining outcome is lymph node status. The most important factor determining lymph node metastasis is the depth of invasion, which we'll go over a little bit more on the next page or two. And femoral and inguinal lymph nodes are the sites of regional spread. So there is sheet-like growth with infiltrating bands and single cells, and there's often desmoplastic and inflammatory stroma. So squamous cell carcinoma is classified by HPV status. So you can have HPV-independent squamous cell carcinoma or HPV-associated squamous cell carcinoma. And again, another really nice table here, modified from the CAP cancer protocol template for vulva. So be sure to reference that. And there are other variants for squamous cell carcinoma, such as basaloid. You can have keratinizing, and then we also have verrucous carcinoma, which is a highly differentiated exophytic squamous cell carcinoma variant with prominent acanthosis, minimal nuclear atypia, and superficial cells with abundant eosinophilic cytoplasm and broad pushing invasion with an associated inflammatory infiltrate. So lymph node metastases are very rare, and the verrucous carcinoma is HPV negative. So some other tumors to think about are melanocytic nevi. So like nevi elsewhere on the skin, but you want to remember that the vulva is a special site. As such, there can be concerning but benign changes, including pagetoid spread, moderate cytologic atypia, and adnexal spread. You can also, of course, get melanoma, which is malignant with variable appearances, such as epithelioid to spindled. You can also have basal cell carcinoma, Bartholin gland carcinomas, and adenocarcinoma of the Skene glands. The next category is unique vulvar mesenchymal lesions. The first of which is a fibroepithelial stromal polyp. So this is benign. You're going to have polypoid growth with variably cellular central fibrovascular core covered in squamous epithelium. The stroma contains predominantly bland spindled cells, and you can see multinucleated stromal cells with degenerative type atypia, including significant pleomorphism. For IHC, the stromal cells are going to be positive for ER, PR, and Desmond, and these fibroepithelial stromal polyps are most common in reproductive age women, and they can grow during pregnancy, which would make sense if they're positive for ER and PRs, as you have various hormone fluctuations at that time. All right, next up we've got massive vulvar edema. So this is also called vulvar hypertrophy with lymphedema. It's a reactive non-neoplastic process, likely due to lymphatic obstruction. It's associated with obesity and immobilization. It may present with generalized vulvar enlargement, papillomatous plaques, polyps, or pedunculated masses, and dermal edema with uniformly distributed cells, and dilated lymphatics, as shown here in this image. You see these lymphatic channels that are quite dilated, larger than you would imagine. And you can also see perivascular inflammation in this process. Next up, we've got deep aggressive angiomyxoma. So this is benign despite the name of aggressive, but it does have a tendency to recur after incomplete resection. Deep aggressive angiomyxoma often presents as a cyst in reproductive age. It's large with more than 5 centimeters in size, often poorly circumscribed, infiltrative, and has a gelatinous consistency. Histologically, you're going to have low-grade hypocellularity, composed of small, bland spindled cells with scant cytoplasm, numerous blood vessels of varying sizes, including thin-walled capillary-like and thick-walled arteries, with radiating perivascular smooth muscle. It invades fat and muscle, with extravasated red blood cells and no mitotic activity or atypia. For IHC, it's going to be positive for ER, PR, and Desmond, and plus minus for CD34. The molecular for deep aggressive angiomyxoma is an HMGA2 rearrangement, and the treatment is complete surgical resection. Most people are treated with the first surgery. Moving right along, we've got superficial angiomyxoma. So this is benign with localized recurrences. It's small, often under 5 centimeters, exophytic polypoid mass, centered in skin and subcutaneous tissue, hence the name superficial, and it's often multilobulated. It's well demarcated but unencapsulated, and you have hypocellular myxoid nodules in the dermis, with bland stellate and spindled cells and inflammatory cells. Classically neutrophils with numerous delicate vessels, and it can envelope the skin and adnexal structures or epithelium. The next entity is cellular angiofibroma. These are benign, usually painless superficial masses or polyps, often small, under 5 centimeters, and they're quite rare. So they're circumscribed but unencapsulated, often trapping fat at the edges, and they're composed of uniform, bland, spindled cells and fibrous stroma, with small to medium-sized blood vessels with thick hyalinized walls. So this sort of resembles a spindle cell lipoma, but with wispy collagen. Next up, we've got superficial myofibroblastoma. So this is benign. It's discrete and unencapsulated. Usually it's small with oval to spindled cells with wavy nuclei and scant cytoplasm, and there's fine collagenous stroma with varied architecture. So for IHC, you're going to have positivity for Desmond, ER and PR, and plus or minus for CD34. A lot of these are kind of along a spectrum and very similarly named, so it's good to just review this and just be aware that there's different entities that can look quite similar but with certain distinct features. Next up, we've got angiomyofibroblastoma. So this is benign, non-recurring, with alternating hypocellular and hypercellular areas, with spindle and plump epithelioid or plasmacytoid cells, and prominent small to medium-sized blood vessels, as the name suggests, with angiomyofibroblastoma. Again, positivity for Desmond and ER and PR, with negativity for CD34. All right, moving along, we've got lipoblastoma-like tumor of the vulva. So these are rare, but they may recur, and it's an adipocytic tumor with lobulated growth with variably sized septa. There's an admixture of adipocytes, univaculated and bivaculated lipoblasts, and bland spindled cells. There's variably myxoid stroma with thin-walled branching vasculature, and you must rule out a myxoid liposarcoma, so there's no DDIT3 rearrangement, or lipoblastoma, which there would be no PLAG1 rearrangement, or spindle cell lipoma, making sure there's no RB1 region gain or loss. So the next entity is a post-operative spindle cell nodule. These are benign, presumably reactive spindle cell proliferation at the site of a prior procedure, usually within a few weeks of surgery, and usually poorly defined in less than 3 centimeters. And histologically, you're going to see these loose intersecting fascicles of spindle cells associated with chronic inflammation and edema, which makes sense. It's kind of just the spindle cell response to a previous site of operation or a prior procedure. So there's some chronic inflammation, some edema, and some spindled cells. So the body's just kind of reacting to that. So again, a lot of those entities we just went through, the variations, kind of confusing nomenclature. They all sound the same, and a lot of the histological descriptions were quite similar. So I would suggest just kind of reviewing this table. It seems like a nice place to review everything in one spot. Maybe a little simpler than sifting through the last couple pages. So you can review superficial myofibroblastoma, cellular angiofibroma, angiomyofibroblastoma, deep aggressive angiomyxoma, and fibroepithelial polyp. So just to kind of sift through those, what you're going to see histologically, and then the various IHC panels. So super helpful table, and would recommend reviewing that. And that's actually it. That's the end of the video. Thanks for bearing with me. I hope it was helpful, and we appreciate your support, and I hope you have a good rest of your night, good rest of your week. Thanks a lot.